be estimated from these scans. So by chance, you have the opportunity to screen people and to come up with a sort of risk calculation and give an advice to the patient and say, well, maybe your fat level in the liver is really high. So maybe visit the internal medicine department or do a lifestyle intervention. So I think that is one way to deal with this knowledge. The other way is what I thought is to do imaging. Yeah, it's maybe complicated. And there are other ways. Once we know what is important in drug trials and in metabolic derangements, then, for example, visceral fat we know is quite important. But there is a trick. You don't have to do imaging. You can just type in your BMI and age, weight, and all these things. And then you also have an estimation of your visceral fat. So that approach. What we do is we try to discover what is important, and then we try to replace that by a non-imaging test or with an opportunistic screening by chance in an imaging test.
Okay, thank you, Prof. Lam. Very interesting. And there is a data that you show me on your lecture about the difference between the Asia and Western population regarding the renal parenchyma and also sinus fat volume. You stated different. Is there any genetic aspect related with those difference, or is there any explanation about the difference?
Yeah, so far, of course, we don't know yet. We did not study the genetic components, and it was also, of course, in a very small group. It was a very small sized trial. It was also sponsored by Novo Nordisk. I saw that they're also in your list there. And yeah, to conduct a large-scale study, that's of course really expensive. So that's why we focused on the sensitive MR techniques and not so much on the genetics, but there will be a component there. But one other hypothesis that we have and testing in some other studies is that, of course, more or less everybody is the same, but in different genetics makeup, the timing of your disease can be different. So that's what we see in the South Asian people, is that they develop diabetes on an earlier age. So maybe that is the effect that we see, that differences can be explained by just the early onset of disease. So you have a longer history of diabetes and metabolic derangement than compared to other groups. So that is also important, because if that is really true, maybe we should screen, for example, South Asians descent people earlier in life, when they are still in their 20s or 30s, to prevent all the derangement and diabetes, for example.
Okay. Thank you, Prof.
Can I follow up for your questions, Dr. Giri, from your questions?
Yes.
Yeah. Regarding the difference of ethnicity, Professor Lam, you develop calculation, right, to approximate, predict the visceral adipose tissue. So would it then be applicable in other ethnicity as well, because you develop the formula using the from Netherlands test group, for example? And what kind of measurement that you use? You're using MRI or CT scan?
Yeah, so for this first study, we used MRI, and that was just to quantify the visceral fat and subcutaneous fat volume. But this was only referring to the visceral fat calculations. And it was indeed developed mainly in the UK Biobank also, and the NEO study, what we do combined. So it was really large number of people, but the majority was indeed from Western descent. So I think the next step would be to add ethnicity in the formula and recalculate it. But yeah, maybe that is a nice opportunity to collaborate because you need a lot of data. So if you have a couple of thousand CTs or MRIs, it doesn't really matter. As long as you have the abdomen image, then we can try to adapt the formula. That would be really interesting indeed.
Yeah, thank you, Professor Lam. Thank you, Dr. Giri.
Yeah. Yeah, very interesting because this session we've been talking from the upstream, the talk delivered by Prof. Lam, and also downstream we have Dr. Hari Sakti also talk or discuss about the medication when the complication happen. Can I move on to Dr. Hari, Dr. Diki?
Yeah, sure.
Yeah. Thank you, Prof. Lam. So I continue to Dr. Hari. Dr. Hari, excellent lecture from you that I want to ask is, you mentioned about SGLT2 inhibitor that has benefit in heart failure regardless the diabetic status and also regardless the ejection fraction status. So if patient with heart failure, you just give the prescribe the SGLT2 inhibitor, and then as you said on your talk that the outcome is very good to reduce the cardiovascular outcome. And the problem is most our patient actually has cardiorenal syndrome or patient heart failure with CKD. And is there any suggestion from you? How about patient who is indicated in treatment of SGLT inhibitor but has CKD? Thank you.
Yeah, okay, thank you very much, Dr. Biri. So, of course, the cardiorenal syndrome is very frequent in the patient with heart failure, and vice versa, of course. That's also one of the concerns because the SGLT2 inhibitors works at the kidney. So, one of the hypotheses show that if the kidney has a failure or reduce the function of the kidney, also they expect that the SGLT2 inhibitor also will not work because it's mainly work in the kidney. But what we can find actually in this patient in heart failure with kidneys or kidney disease, of course, in the study they only include in the DAPI CKD patients. We call the DAPA CKD studies. They include only the patient with heart failure and at least a GFR more than 30. And they found even in the patient with the chronic CKD with a GFR more than 30, they found that the SGLT2 inhibitor is safe, and also even further it can preserve the kidney function compared to patients who did not use SGLT2 inhibitors. Although sometimes we have to be very careful because in the study it's shown that at the beginning, at the early initiations of SGLT2 inhibitor, there's a tendency to increase of the creatinine levels. In the early, maybe the first week of the treatment, there's an increase of the creatinine level, but after a long-term observations, the kidney function is rather preserved compared to patient without SGLT2 inhibitor. There's several discussion about this, sometimes because some of the medications of the heart failure, like such as furosemide, also can affect the reduction of kidney function or the heart failure itself, or the heart failure improvement in the patient with heart failure reduced ejection fraction can improve the circulatory problems and improve and reduce the cardiorenal syndrome and preserving the kidney. So there's so many actually we can talk and study about why that SGLT2 inhibitor shown that it can have a very good effect not only in the heart but also in the kidney. But for now, the clinical application dictates that if from the DAPA CKD studies showed that in the patient with heart failure and at least eGFR more than 30, we can still use SGLT2 inhibitor, and even further, it can preserve the kidney function on those patients. Maybe that's my answer for your questions. So question.
Thank you, Dr. Hari.
Yeah.
Dr. Tiki, I think we have audience who raised his hand.
Dr. Farid. Dr. Farid Kurniawan raised his hand. Please, Dr. Farid.
Yes, thank you, Dr. Diki, and thank you, Professor Lam and Dr. Hari, for very excellent lecture. I have questions for Professor Lam and then later also for both of you. First questions for Professor Lam is like, you mentioned about the triglyceride plasma, triglyceride content is increased in the heart and also in the liver. I was wondering whether this triglyceride content is correlated with the triglyceride plasma. I don't know whether I missed that or not. And the second question is, if you can measure triglyceride content in this, like say, obesity patients or diabetes patients or pre-diabetes, would you can use it as a predictor of later that these patients will have heart failure, whether just preserve or reduction of the ejection fraction heart failure in the diabetes patients. And my last questions for both of you, Prof. Lam and also Dr. Mulyawan, regarding the SGLT2 inhibitor. If I'm not mistaken, there is no receptor of the SGLT2 in the heart. I was wondering whether if you measure this fat content or this triglyceride content after or before using the SGLT2, whether it will affect the content and it will eventually affect the heart failure itself. Thank you.
Okay, please, Professor Lam.
Yeah, maybe go back to your first question about the triglyceride level in the plasma. We measure that in all the studies, and one nice example is that it doesn't really help is the high fat diet with drinking cream for 3 days. There we saw an increase also in the triglyceride levels in the blood plasma. In the liver, that correlated to the liver fat accumulation, but in the heart it did not, because in the heart there was no fat accumulation. So we think indeed that the uptake of the lipids by the cells is regulated in a way that we do not fully understand. Also, especially in diabetes, in patients with even normal levels of triglycerides and free fatty acids in the blood, they still have an increased uptake of fat in the cardiomyocytes. So it's not a sort of overload effect of blood lipids, but it's something else. It's upregulation or hypermetabolism or a switch from glucose to fatty acid metabolism in the cell, and then with a higher demand for lipids from the blood. So you can use the blood sample to predict the triglyceride level in the organs. Maybe there are other ways to do that, combining other factors. For example, in the liver, we did some studies looking at the CETP, that is a blood marker that reflects the macrophage activity, or actually the Kupffer cell activity for inflammation, and that related a little bit to the liver fat. But there are also other ways of predicting these fat levels in the liver. That's not difficult. In the heart, we could not do it yet. So yeah, that's a pity. So you cannot use that as a simple blood marker, actually. Second question, what was that?
And for my second question regarding the triglyceride content in the heart, could you use that for the later prediction of the heart failure in diabetes patients?
Yeah, that's of course the million-dollar question. Is it useful? So now we are conducting what we call the NEO study, that is the Netherlands Epidemiology of Obesity study, where we are now rescanning patients after more than 10 years. So we included them a long time ago. Now we're doing a follow-up scan in thousands of these patients. And now, since the technique is now developed, we can also add the myocardial fat spectroscopy. And we already did that now in about 500 subjects, and we will go on for, I think, close to 4,000. Then we will follow these patients over time, the next 10 years or as long as they live, and then hopefully we can look back and then predict the value or see the value of the heart fat. We don't know yet, but that is one of the main goals of the NEO study, and that took a lot of effort. I think I spent 5 PhD students to convert the technique from about half an hour acquisition time to only 5-minute acquisition time. So it's a quite unique technique, that people can copy or they can get the source code. It's available for everybody. But in our case, yeah, we developed it for a Philips platform. But if you have a Philips scanner, everybody can do it now in a very easy way. So you don't even have to understand how it works, because there are lots of automations and corrections and things going on the background. And that the idea is, of course, that it can also be used maybe when we prove it's useful in a clinical setting. And yeah, your question about SGLT2 drugs, we didn't do any trials, so maybe that's a good question to my colleague presenter.
Okay, thank you, Professor Lam. And now go to Dr. Hari. Please, Dr. Hari.
Yes, thank you. Yeah, actually, there's also one of the questions. Actually, I want to ask Professor Lam whether you have any experience with SGLT2 inhibitors and seeing the fat content also in the heart, because as we know that the SGLT2 doesn't have any receptors in the heart, in the cardiac. So several hypotheses that the SGLT2 can affect the heart is through the metabolism factor, can reduce the insulin resistance, and also apparently the SGLT2 can also reduce the fat content in the liver. So one of the study also shown that that the SGLT2 increase with beta hydroxybutyrate of ketone bodies, and from those ketone bodies increase the bioenergetic in the heart. And another hypothesis also there's for some reason that the SGLT2 inhibitor affected the natrium, the sodium hydrogen exchangers, and improve the calcium handling, like in circa. So it can improve the contractility and improve the energy in the cardiac. But for now, we still don't know for sure what is the effect of SGLT2 in the heart. We only know the clinical implication. Somehow the SGLT2 inhibitor can improve the cardiovascular outcome, but still I think we still not clearly know what happened. So I think if possible, again, we can make a collaboration with the SGLT2 inhibitor in the patient and see the fat content. I think it's very, very interesting. So I also interested in the seeking for the bioenergetic factor, whether the SGLT2 inhibitors can improve the cardiac function from the bioenergetic from the ketone bodies, because several studies show that ketone bodies can also improve cardiac function. Whether those actually what happened in the patient with SGLT2 inhibitors, we still don't know. Maybe those maybe those are my answers.
Yeah, maybe
Okay, thank you, Dr.
If I can add,
You want to add something, Professor Lam?
Yeah, maybe one short thought, because now you have also recently tirzepatide, that is another GLP-1 analog that seems quite potent in reducing the body weight by about 20%. But one of the ideas indeed is to combine that with the SGLT2 inhibitors. So that could be really, really interesting to perform randomized trials to compare separate or combined drug applications for combined effects on cardiovascular, but also on fat distribution elsewhere in the body. That is quite intriguing.
Yeah.
Okay, thank you, Professor Lam. Yeah, of course, there's still a lot of burning questions, but because for the sake of time, we already late from the schedule. Thank you very much, Professor Lam, Dr. Hari, and also Dr. Biri, and all the attendees for the very nice discussions. Hopefully, this session would not stop until today, and hopefully we can also expand collaboration as well, Professor Lam. So Dr. Biri is from the Integrated Cardiac Center from Cipto Mangunkusumo Hospital, one of the biggest hospital in Indonesia. Also Dr. Hari from the Universitas Indonesia Hospital, also from Harapan Kita as well, right, Dr. Hari?
Yes.
Also the biggest cardiology center as well. So hopefully our meeting would not stop here, and we can further collaborate in research also in management. Thank you again, Professor Lam, Dr. Hari, and Dr. Biri, and all the attendees. I would like to close the session, and I would like to give the time back to Natasha. Please, Natasha, time is yours.
Thank you.
Thank you very much, Professor Hildo J. Lam and Dr. Hari Sakti Mulyawan for the very interesting presentation. Thank you as well to Dr. Diki Leverus Tahapari for being our moderator and Dr. Biri Karim for being our panelists. Next, we will now watch a video by our sponsor, AstraZeneca. To the technical team, you may now play the video.